It's low bone mineral density with microagricultural deterioration of bone tissue. And this leads to increased risk of fragility, which is minimal trauma fractures. As defined by the WHO, osteoporosis is a DEXA scan T score of less than 2.5 standard deviation or a history of a minimal trauma fracture. In patients with a T score less than 2.5 but greater than -1, it's defined as osteopenia. We can't use T scores in the premenopausal woman, so we use Z scores, which is age match related. And this is defined as osteoporosis as a standard deviation of less than or equal to -2 or a history of a previous fragility fracture. And what is concerning is in older women, the lifetime risk of a minimal trauma fracture is almost 44%, which is higher than the risk of breast cancer and ischemic heart disease. But often in a clinical setting, we ignore this risk. Fractures are debilitating, resulting in loss of mobility, decreased independence, and risk of long-term care. And this is a great burden on the patient, as well as a financial burden on the health low BMI, secondary causes, a diet low in calcium and protein, restricted sunlight, sedentary lifestyle, smoking, alcohol, and increased propensity to falls. So a question I often get asked by registrars is, who do we scan? And the National Osteoporosis Foundation of South Africa recommends DEXA scanning in any patient who has two or more of these risk factors. Furthermore, there is an internet-based score, the FRAX score, which is used to determine estimated fracture risk over 10 years. It has flaws in that some countries have their country-specific thresholds. South Africa, we are yet to establish that. US has a very good system where you compute in all the patient risk factors. You don't even need a DEXA scan. And their high-risk patients are basically anybody who is at risk of a major osteoporotic fracture greater than 20% or a risk of a hip fracture greater than 3%. Patients who have had a history of a fracture or who have osteoporosis as defined by a T-score should receive pharmacological treatment. Our guidelines differ from international guidelines. The UK and the US say that all postmenopausal women should have DEXA scans. And in the premenopause, women should be screened for risk factors, and anyone who's had a fracture or any chronic disease affecting bone metabolism should have a DEXA scan. Obviously, in our setting, because of resources, we cannot do this. What are the clinically significant secondary causes of osteoporosis that we as clinicians need to be aware of? And I've highlighted the ones that are particularly relevant to us, and those are patients with hypothyroidism, primary hypothyroidism, premature menopause or premature ovarian insufficiency, anorexia, prolonged use of glucocorticosteroids, SSRIs, PPIs, and depot. In normal patients, peak bone mass is the maximum amount of bone an individual has by the time a stable skeletal stage has been reached, and this is during young adult. So what determines your peak bone mass? It's 80% genetic factors. The remaining 20 are your diet, lifestyle, your hormonal status, as well as your physical activity. NOFSA has recommended that throughout a woman's life, calcium intake and physical activity is required for the development of peak bone mass, and we'll go into that and the recommendations later on. The recommended daily intake of calcium required for young girls aged 9 to 18 is 1,000 to 1,300 milligrams per day. Level of physical activity is most beneficial to bone health. And now we have these young girls on their tablets and laptops sitting and watching all the social media the whole day. And they're not out there doing weight bearing and excess exercise, which has been shown, and I'm going to present some studies later on, to be extremely beneficial for bone later in life. Um, in terms of vitamin D supplementation is recommended for postmenopausal women, but not in the premenopause unless they are deficient in vitamin D. Okay. So this is a graph looking at your peak bone mass. Most of women receive their peak bone mass around the age of 30, but in your lumbar spine, this continues till about 40. Factors that affect it is chronic diseases, as I've mentioned, altered puberty, decreased physical activity, as well as calcium intake. From the third decade of life, unfortunately, we start losing bone, and this continues till postmenopause. We know pregnancy and breastfeeding can affect this. Okay. We have the entity of pregnancy and lactational osteoporosis, but that is in severe cases. But pregnancy and breastfeeding changes calcium metabolism to nourish the growing fetus. During lactation, intestinal decrease. So you have predominantly bone reabsorption to provide that calcium to the fetus. Hence, bone mineral density can reduce up to 10% during breastfeeding. Most studies have demonstrated bone density recovery within 12 months of weaning. In long-term, evidence suggests that pregnancy is actually thought to protect against BMD loss because there's this hypothesis that your bone is losing and regaining, and some studies have demonstrated that you regain at higher values to your peak bone mass. However, evidence suggests that high parity has been associated with lower BMD later in life. So osteoporosis in the premenopause, as I've mentioned, is defined as a Z-score of less than -2. A Z-score for registrars is a comparison of average age match and sex match BMD. And -2 is basically defined as below the expected range for age. The causes of osteoporosis in premenopause are menstrual disturbances, particularly functional hypothalamic amenorrhea that's found in elite athletes who overexercise, contraception, pregnancy and lactational osteoporosis, breast cancer, as well as premature ovarian insufficiency. I'm going to go through these topics that are particularly relevant to us. The first is Depo. Depo is the most common used contraception in South African women. Okay. Evidence suggests that up to 5 years of Depo use with 2 years of discontinuation is associated with up to a 5% decrease in your bone mineral density, particularly at your total hip and lumbar spine. The most rapid decline in your BMD is in the first year of use. In evidence of Depo versus non-hormonal groups, there has been significant decreases in bone mineral density. Depo use has been further associated with increased fracture risk. But when we look at the evidence of fracture risk, the risk is actually quite small. I mean, what is 1.7 compared to the general population? So the ACOG released a statement regarding Depo use. We know Depo is an effective contraception, right? And patients use it. However, use of beyond 2 years, you have to be a bit cautious. So if you look at evidence regarding the use of 2 to 5 years and follow up to 5 years after discontinuation, recovery at the hip and femoral neck took longer compared to recovery at the spine. In young adolescents aged 12 to 18 with follow up to 5 years after discontinuation, complete recovery was found at the BMD at those sites, but those who used Depo for less than 2 years had complete recovery. Those who used Depo for more than 2 years had delay in recovery. So the recommendation from ACOG is please promote Depo. Contraception is obviously better than no contraception. However, in a young adolescent who is seeking long-acting reversible contraception of more than 5 years, one has to counsel this patient adequately under the use of an intrauterine copper device or an implant. And if they choose not to use that, as that has no effects on bone, then we go ahead with Depo. And there are some evidence that perhaps we need to consider Depo holiday in some patients who want depot for longer periods of time. What about weight? Underweight, BMI of less than 18.5 has been associated with lower BMD than patients with a lower weight. And this low BMD continues till postmenopause. That is predominantly because fat generates estrogen, which exerts both preserving bioactivities. Hence, in early childhood and adolescence, one needs to promote educational programs and dietary advice to promote normal weight in these women. Then in ethnicity, in South Africa, a study done in 2011 compared BMDs amongst black and white females. And black females tend to have higher BMDs, particularly at the lumbar spine, predominantly because they higher BMIs as well as they increase physical activity compared to white females. HIV. I'm bringing this in because HIV prevention is a bit of a special interest of mine. But I'm going to be looking at this in terms of HIV, and the disease itself has been associated with elevated osteoclast activity and reduced bone formation. And there's an increase in TNF activity, which is associated in osteoclast mediated bone reabsorption. Evidence from Australia suggests that HIV infected individuals with combined risk factors of low CD4 counts and concomitant medications such as antiepileptics and steroids are at increased risk of low BMDs. In a local study in 2023, women living with HIV at menopause experienced greater loss in BMD and increase in fat mass compared to HIV negative women. Furthermore, treatment is associated with a reduction in BMD. Earlier studies have shown significant bone loss of 2 to 6% with any ART regime. Then PIs got introduced into the regimes, and that was basically implicated as the driver. Following that came tenofovir. And tenofovir-based treatment has been associated with the greatest bone loss, particularly at the hip and spine, in patients receiving tenofovir-based regimes versus non-tenofovir-based regimes. In 2011, McComsey et al. Found that TDF-based ARVs had a greater impact, causing a decline in BMD of up to 96 weeks compared to other regimes. And why does TNF have that effect? It has a direct effect on bone, um, increasing bone reabsorption, as well as increasing gene expression of both your osteoclast and osteoblast activity. The indirect effects on TDF is predominantly through the renal system, inducing proximal renal tubal dysfunction, and the endocrine system. TDF promotes or stimulates high levels of parathyroid hormone, resulting in metabolism, subsequently calcium absorption, and an increase in bone turnover. That begs the question of, should we be using TDF as PrEP? The WHO has recommended PrEP to individuals at high risk of HIV to be cost effective. And in 2019, the South African PrEP guidelines have included pregnant and breastfeeding women at risk of HIV to receive PrEP together with HIV prevention screening. I was fortunate to be a part of a big trial where PrEP was started to look at in pregnancy in the CAP study, and uh, we then looked at PrEP use and its effects on bone postpartum up to 74 weeks post delivery. And we had 300 women in our randomized control trial. I've got to disclose some of this is published and some of this is unpublished results, or should I say, still to be published results. And we found that we followed up these women up to 74 weeks postpartum, and we measured bone mineral densities at intervals. And we found that adjusting for breastfeeding and BMI, there were no significant differences in bone mineral density or bone mineral content in women who used PrEP versus women who did not use TDF PrEP. We further went on to look at tenofovir levels just to check if patients were compliant. Up to 30% of our patients were fully compliant throughout pregnancy and postpartum period, but we found no dose effect of that tenofovir on bone mineral density. Because we know tenofovir has an effect on renal function, we went on and looked at renal function, and we found no effect on our creatinine clearance over the study period. But what we did found is 16% of our women had renal adverse events, and these women were underweight women and women who had low baseline creatinine clearance. In our study, less than 5% of our patients had lower limits of normal levels of serum calcium, phosphate, and magnesium. Basically, meaning that it seems like our patients are quite, um, sufficient in terms of calcium levels. And TDF had no direct effect on these serial minerals, as well as no impact on BMD. There was a significant inverse relationship between serum phosphate levels and BMD in our study, suggesting potential bone demineralization. So, our recommendation was to suggest a higher dietary intake of phosphate during breastfeeding to prevent bone demineralization. And phosphate predominantly is just encourage patients to drink more dairy products. What's surprising in our sunny Durban is we found a high rate of vitamin D deficiency, 6% in pregnancy and 10% in postpartum. However, these vitamin D levels were not associated directly with BMD, and tenofovir had no direct effect on vitamin D levels. As I mentioned, despite the high prevalence of vitamin D deficiency, reassuring is this was not predictive of BMD of the hip and lumbar spine. Moving on to the postmenopause. As I've mentioned, postmenopause is basically associated with reduced estrogen, and this results in net bone reabsorption and a decrease in net bone formation. BMD from risk factors early in life can cause accelerated bone loss later in life. Following menopause in women, initial rapid trabecular loss occurs of up to 1 to 2% annually. And longer than 10 to 20 years, there's obviously a slower bone loss affecting both cortical and trabecular bone. How do we manage patients? The International Osteoporosis Foundation suggests that, as we mentioned, the RDI for younger patients is 1,000 milligrams of calcium per day. However, in postmenopausal women, all women should be supplemented with at least 500 milligrams. There are studies that are done with higher doses in postmenopausal women. However, these are associated with adverse cardiovascular events. So please don't think the more the better. Vitamin D in the premenopause, there's only benefit in a patient who is deficient. In the postmenopause, vitamin D supplementation is recommended at 800 to 1,000 international units in women more than 60, because as we know, vitamin D enhances calcium absorption. Protein. We all mock protein shakes, but they've been implicated in protective and being protective against bone loss. Studies have been looking at both plant and animal-based protein. The recommended daily allowance should be 1 gram per kilo per day. Okay, there's some evidence that seniors with fractures, if we supplement them with these protein shakes, they have a reduced risk of future fractures. General other lifestyle measures is we know smoking and alcohol is implicated in reduced bone mineral density. So in those women who smoke and drink, tell them to cut down or stop. We mentioned earlier that exercise during childhood and adolescence changes your bone structure and geometry, resulting in a greater diameter of bones and stronger tubercular architecture, which reduces risk of fracture later in life. And these include weight-bearing exercises. Walking down the promenade with your friend, chatting on your phone, is not going to protect you against osteoporosis. So brisk walking, hiking, stair climbing, jogging, high intensity progressive resistance training like lifting weights, and high impact exercises like jumping and rope skipping has been associated with an increase in your bone mineral density of up to 1 to 4% per year in both the pre and post menopause. Weight bearing exercise also improves gait, muscle strength, and balance in seniors. Okay, and this can result in an up to 50% reduction in falls. As we mentioned, light, strolling down the promenade, and non weight bearing exercises, even swimming and cycling, does not enhance bone density. Further evidence looks at exercises with certain food products, and in an India study they found this millet, finger millet foods, which is a cereal, together with weight bearing exercises, improves bone health pre and post menopause. Sleep, how long should we sleep? So, in postmenopause, the United States recommends that all women should sleep at least 7 to 9 hours. Less sleep is associated with increased risk of cardiovascular disease and bone health. In Swanson et al. In 2018 demonstrated that sleeping less than 7 hours a day results in lower BMD and increased risk of osteoporosis. Registrars, I'm sure you're not sleeping 7 to 9 hours a day. However, there are some studies that dispute this, but most recommend at least 7 to 9 hours a day. Furthermore, we know medical comorbidities like diabetes and dyslipidemia can result in oxidative stress and reduce bone mineral density. So these patients need to be adequately managed. So the National Osteoporosis Foundation of the United States recommend in postmenopausal women adequate amounts of calcium. And as I mentioned, supplement with at least 500 milligrams. The rest a patient must drink in terms of dairy products, milk. Supplementation of vitamin D, at least 800 to 1,000 units, and advise on regular weight bearing exercises and muscle strength exercises, right? Also, advice on avoiding bone toxic drugs. We have a lot of patients on high dose steroids for long periods of time, but any patient on high dose glucocorticoids such as prednisone for more than 6 weeks, those are associated with lower risks of bone mineral density. So we try and restrict that use. So, how do we manage patients? Medical therapies for premature ovarian insufficiency, the cornerstone is hormone replacement therapy. And hormone replacement therapy should be administered till the age of 50 to 51 to basically preserve BMD. Furthermore, hormone therapy also assists and alleviates these vasomotor symptoms. In the postmenopause, menopausal hormone therapy is the first line for the prevention of fractures. Um, it improves BMD and prevents fractures later on. A meta-analysis by Wells et al. Showed BMD was significantly higher in menopausal hormone therapy groups at all sites. After 2 years of use, you can have your bone mineral density increase up to 6.8% and 4% of the femoral neck. The International Menopausal Society recommends menopausal hormone therapy as a first line in women at risk for fractures before the age of 60 and within 10 years of menopause. However, once menopausal therapy is withdrawn, those BMD gains disappear rapidly within 3 to 4 years. Okay? So, what alternatives do we have? Tibolone is available. It's a synthetic steroid with estrogenic, progestogenic, and androgenic effects. It has been shown to be efficacious in preventing bone loss and reducing the risk of fractures in older women. However, we are restricted in terms of its side effects. The second is selective estrogen receptor modulators. Roloxifene reduces the risk of vertebral fractures, but it's restricted in its use in that it doesn't reduce the risk of non-vertebral fractures. It's useful in a patient, particularly breast cancer survivors, as it reduces the risk of estrogen receptor positive breast cancer. Bazodoxifene is also registered for use for the prevention of vertebral fractures, and it's used in combination with estrogen. It prevents menopausal related loss of BMD, but a lot of studies have no fracture endpoints. The hallmark of therapy is also bisphosphonate therapy, which reduces the risk of vertebral and non-vertebral fractures in women. And commonly we have oral alendronate available, risodronate, and ibandronate, and the intravenous forms. Women with osteoporosis taking alendronate over 2 to 3 years have a reduced risk of both vertebral and non-vertebral fractures. And this similar risk reduction is seen with our other oral bisphosphonate therapy. Zoledronic acid reduces the risk of vertebral fractures as well as hip fractures, but these obviously it's an intravenous infusion that has to be taken at baseline, 12 and 24 months. The decreased vertebral fracture risk persists up to 18 months following a single dose of treatment. However, it is expensive. A big concern with bisphosphonate therapy is the side effects, and that includes osteonecrosis of the jaw as well as atypical femur shaft fractures. The initial rise in BMD and therapy in all your bisphosphonates is basically within the first 3 to 5 years. Because of the side effects, a drug holiday is warranted in any patient on bisphosphonate. Those on oral therapy, a drug holiday must be done after 5 years, and IV therapy after 3 years. Following this drug holiday, we can assess whether the patient requires further treatment again. Other drugs that we have available is denosumab, which is a human monoclonal antibody against rancor. It improves mass and strength in both cortical and trabecular bone, and it's been associated with significant reductions in the risk of hip, vertebral, and non-vertebral fractures. However, it's restricted by the cost, and the effect on bone rapidly wanes off. And if therapy is interrupted at any point, you've got the risk of rebound fractures with a rapid increase in bone reabsorption following cessation of therapy. Our recombinant human parathyroid hormone, teriparatide, is a very good drug. However, it's extremely expensive. It's not easily available. Um, it's been associated with reducing both vertebral and non-vertebral fractures in postmenopausal women. Another human parathyroid hormone, abaloparatide, has also been studied, and it is very effective in reducing fracture risk. However, we are restricted by the cost and availability of this drug. Um, Osteoanabolic agents include romosozumab. It's a potent anabolic agent with some anti-resorptive effect. There's a reduction in both vertebral and clinical fractures, up to 70% in vertebral fractures and 36%. It's a monthly subcut injection that's highly expensive and not easily available. But when we look at it and compared to bisphosphonate therapy, it seems to be superior in risk reduction of fractures as well as BMD gains. So, who do we treat and with what? The International Menopause Society in 2021 has these following recommendations to guide clinicians. So, in women who are postmenopause at low risk of fracture, we optimize their calcium and vitamin D status and promote a bone friendly lifestyle. Women at high risk of fractures, we should optimize calcium and vitamin D status as well as promote bone friendly lifestyle, but we need to start therapy. And the first line therapy will be hormone replacement therapy or bisphosphonate, followed by SERMs or denosumab. Patients at very high risk of fracture, we should consider anabolic therapy. Um, and if we can't, then we go on to bisphosphonate therapy. Okay. So, a recap of our bone health throughout your life. In all girls at puberty and premenopause, please encourage calcium intake, vitamin D, getting some sunshine, not sitting in the house with the tablet and laptop and whatever these kids do these days. Physical exercise, and that includes weight bearing exercises, and always assess for secondary causes in these women. Pregnancy and breastfeeding, Obviously, there's always pregnancy planning, and any woman who has secondary causes where there's risk, we need to take into account the risk of fracture, optimize calcium intake during this period. In all women with premature ovarian insufficiency and early menopause, that's less than 40 years, hormone replacement therapy is the gold standard until the average age of menopause, which in our setting is 51, 52 years. In women with early late menopause at low risk of fracture or a moderate risk of fracture, hormone replacement therapy or bisphosphonate therapy should be recommended, and very high risk if you have resources, your osteoanabolic agents. But in our setting, it's difficult. Bisphosphonates would probably be the only option. So, in conclusion, bone health is important, and I think we as clinicians we often ignore it. We too consumed with pregnancy and HIV, AUBs, but we need to take into account that bone health throughout your lifespan has an effect on your bone health in the menopause. So, in all women, we need to promote adequate calcium and vitamin D intake, as well as weight bearing exercises from childhood. Women should avoid bone toxic drugs, tobacco smoking, and excess alcohol intake. In all postmenopausal women, don't only focus on postmenopausal bleeding. Evaluate these patients for any present or future expected bone health, as well as risk of fracture. And a bone friendly lifestyle should be promoted. Any patient who has a fracture or is at high risk of fractures, we need to consider bone specific medication. And in our setting, that would be hormone replacement therapy and bisphosphonate therapy. Because osteoporosis is a serious, uncurable, lifelong disease. Thank you. Um, oh gosh, I finished early. I'm going to open the floor for any comments or questions. Yes. So we have different levels. So there's a lot of studies looking at adherence thresholds, 1 to 2 pills a week, 1 to 4 pills a week. So the rest of the patients took less than the adequate dose. So they may have taken 1 a week as opposed to the 4 a week to achieve therapeutic levels. No, there was no difference in the bone. Yes, that was just for PrEP. No. Well, I think the degree of the question is in patients with premature ovarian insufficiency or failure, is lifestyle and calcium vitamin D sufficient for treatment? I'm going to say no, because the degree of estrogen deficiency is so low that these women are at increase of osteoporosis and fractures later in life. So the to start hormone therapy, unless there's a contraindication to hormone therapy, then we have to readjust and maybe consider another agent. Okay. Prof. Hmm. Yeah. Mm. Mm. Yeah.
after we've known about the BMD of effect of therefore our women are HIV over 30% of medically productive children. So we should really be staying away from them in our setting, at least in those women that are low. So our alternatives are some other drugs, like implanon, Mirena, and so forth. Does this progesterone effect of therefore in the bone has it been compared with these other agents which are also progestogenic? So I know I'm stretching you beyond your
point. Yeah, it's stretching. Look, if you look at the studies on implanon, but also, implanon is relatively new. There's so much more to do on implanon. There hasn't been any studies to demonstrate any risk on bone on implanon or Mirena. So that is why it's advocated that we should be promoting even those progesterone products rather than depot, because there's enough that there's a reduced risk. But if anybody has come across anything, but the studies I've come across haven't demonstrated any significant risk on implanon. But it's still early days. Maybe that somebody is MED or even further to look at that in comparison to depot and the effects. But I think for now, no, Prof, unless you know of any studies.
I'm 20% fine. I'm expecting someone just anyway, because that's the problem.
There's a follow-up from the national is following up. Yes, there is an impact on mineral density, but there in association with fractures.
Yeah, we were looking at that. Any study, if you tweak some stats, things will become significant. I'm sure Prof will tell you. She's been involved. But it's a 1.17 risk. Your relative is 1.17, an increased risk of fractures. Yeah.
What I'm saying is the baseline, the weight of it is the third one. Obviously, except for people that are there are more and it's vitamin D is not a we'll find that the and I doubt unless I'm wrong that this therefore, although that different associated with fracture, they demonstrable increase in fracture risk in the third world way between in the first world definitely not induced function. So I also would want to see where this data comes from in terms of that if they say fracture risk is eventually increasing, but we do take note of what they are saying. So I was just following up on that. Unless somebody has data that says that work an increase in fracture. But I'm sure in towns where people are actually vitamin D deficient because you are in your car, you are indoors, and there is no exposure to the sun. Maybe the only time you get exposure to the sun is the weekend. And I don't know how much exposure to the sun is the weekend is doing. So that's why you are beginning to see vitamin D deficiencies, which we denied for many years. No, it doesn't exist in Africa, but people have shown that it does exist. Those studies also show that 6% premenopause and about 10% postmenopause and 11%.
No, pregnancy and lactation.
Lactation, that way it was 10%.
Yeah.
Oh. Now, the other thing before you want to take over, I had a question because when you recommended vitamin D supplement, you said less than the age of 50 is the amount, and then you jump to more than the age of 60. Now, wondering between 50 and 60, will we stop the vitamin D or there is no vitamin D that's required there because we didn't speak to that. We just jumped over to 50 and over 60. They know.
Yeah, no, Shem, I think most think there was just a difference in guidelines, but I think the more than 60 and the greater than 60. So most of our supplements should be in women more than 60.
Biphosphonate. Is there no limit to the duration of biphosphonate?
Yeah, we just said so because of the risk of osteonecrosis of the jaw and atypical fragility fractures, we for oral treatment, it's 5 years, IV 3 years, and then they take a drug holiday. And then you assess the patient and assess, okay, do they need, and that drug holiday could be 18 months to 2 years, check their bone density and assess and see, do they need to go on treatment again, or do they need to just stop with lifestyle, continue with lifestyle if they've had significant improvement. But if you're talking about the total duration, no, as long as they have that drug-free interval of at least they can reinitiate. Oh, yes.
Question relates to screening. So obviously we see a large number of women who are perimenopausal and postmenopausal. And you mentioned two options in terms of flagging those we should be concerned about. You said the crack score, which we could consider, and then you've got a list of risk factors, and said some of the two risk factors where we could consider screening. Presumably to that list of risk factors, we should put HIV on that list as well. Now, pragmatic resource constraints set, we should be flagged up. And we flag them up. Do excellent. We put them. So just a pragmatic approach in terms of that.
So I think, as we said, the international guidelines look at universal. In ours, we've restricted ours a bit. So, patients who are on long-term, or patients who have secondary risk factors for osteoporosis, such as our medical disorders, prolonged use of corticosteroids, premature ovarian failure, along with other risk factors like age, significant smoking, significant alcohol history. I think anybody who has more than 2 of those fractures or a previous fracture should be screened. A DEXA scan. As I said, there's FRAX is quite the registrar should actually go on internet. It's quite an intense thing. You'll have to be aware of it. It's quite a long process to calculate it. But the problem with the FRAX score, it's based on US data, and US risk. So is that the same to our setting? Those are the limitations of that. But as I said, if we can compute that, we should. But I think anybody with more than 2 factors should have a DEXA. Because that's the only tool. Obviously, now there are other tools. People are doing ultrasound, trabecular scores, and all of those funny things. But we only have DEXA available. Oh, and breast cancers should be part of it. Yeah. No. This is screening in the post-menopause. Yes. Pre-menopause, it's only patients with those significant risk factors I mentioned, like the premature ovarian, or patients with a previous history of a fragility fracture. Yeah. Depaforolol. And they're HIV positive. Yeah. Population. Yeah.
But is there been studies that are associated? Because obviously in our situation we've got this depot, we've got this HIV, but this ARV stories, which has been on for a while. Is there evidence that shows that this increase fracture?
We'll do that talk next.
Yeah. But we did have that one study that showed HIV positive women at treatment had lower BMDs at menopause. Yeah.
I'm saying
Yeah,
and they on
on treatment with depot, which is almost probably like 30 to 40% of our population. Hmm.
but what do you think we should be excellent
Yeah,
or maybe practice for them at the very least because the practice is nothing
Yeah.
high speed. Maybe starting from the flex or that. But in terms of what we bring practice, as Sean is asking, we can't afford at this point to excellent. But it is a literature review for the maybe correct scoring them exercise for them. And
It's not that.
Totally.
Oh,
No,
oh, yeah, mine. Yeah.
what I say,
He's saying what he's saying.
Thank you so much for the history. From the, please correct me if I'm wrong, from the previous guideline, prevention of osteoporosis or in presence of osteopenia was not an indication in isolation or hormone replacement therapy. I think the primary indication has always been presence of vasomotor symptoms. As much as we know, this is secondary.
Yeah.
I think there it's coming.
Yeah, no, I think
Yeah,
I tried to
yeah.
sell it. Yeah, I tried to sell it, but if you look at all the guidelines, the primary indication is actually for vasomotor symptoms. The bone health is the secondary, but I just mentioned it as a first line management. But I agree with you. Guidelines hormone therapy is actually for vasomotor. The secondary effect of bone health is just where we come in. Dr. Moran.
yeah, maybe following on that. I mean, you presented some recommendations to us, but they don't really align with the national recommendations in terms of the National Department of Health recommendation, particularly with regard to calcium. So national recommendations are not to recommend calcium for postmenopausal as standards. And if you look at the national standard treatment guidelines, they are recommended. It's not clear that there's benefit. That's why it's not there. The only category of people they recommend calcium supplementation to for primary prevention of fracture is frail elderly people in institutions who are not mobile. The only time they recommend calcium supplementation is for secondary prevention. So after a person has already had a osteoporotic fracture, and they would also recommend the bisphosphonates, and that's the category of person who would probably get a DEXA scan. So I think for most of the population who are nowhere near a DEXA machine, it would only come into the question when somebody has fracture, which is suggestive of an osteoporotic fracture. Then you might start investigating osteoporosis. You confirm it, you put them on bisphosphonates and calcium. But it's not recommended as supplementation. And, you know, it's worth looking at exactly the evidence, but it's not clear that it's beneficial. And as you mentioned, there are studies which show increased risk of cardiovascular complications, ischemic heart disease complications. So that's what the national guidelines say. And as Dr. Nadella says, hormone replacement therapy is for troublesome symptoms, not for prevention of fracture, etc.
I think troublesome symptoms and osteopenia higher risk of moderate or higher risk. That's cheaper.
It's not for prevention.
Prevention.
It's not for treatment, but it's an
Yes.
So that was my first point. The second point is back in the depot story.
Let us relay that. I see people dropping off. people that are hearing us.
Okay, no, Dr. Moran just mentioned the national guidelines don't routinely recommend calcium for postmenopausal women. It's just in secondary prevention. If a woman has a fracture, then calcium and bisphosphonate should be given. And then DEXA screening.
Except for frail elderly
Oh, and frail elderly. Yeah,
institutions, and that's the only time for primary
sure.
prevention. Presumably those people want to get exposure to sun and all those kind of things.
Dr. Moran, on that point, I think we need to look at national guidelines.
Oh, yeah. Oh,
We
okay.
need to look at the national guidelines against NOFSA,
Yeah.
because we've got NOFSA with whatever Osteoporosis Foundation of South Africa. Because sometimes the Department of Health, and I'm not saying they do, they may really whatever constraints and not want to screen everybody. So NOFSA aligns with international guidelines, and we cannot then, dilute the effect of all the other things that have been documented.
I'm just saying what the national guidelines are.
I'm just trying to say that we shouldn't, if a patient qualifies and can afford, we should then avail the treatment. It's something else if we are going to give. It's like the calcium we give in pregnancy right now.
Look, so
Do the patient really need it or whatever? But
what I'm saying is national guideline. I'm talking about the calcium. It's as I mentioned, the national guideline, National Department of Health guideline. But it's not based on cost, it's based on evidence, because they've got the references there. There's the evidence prevents fracture. That's so at national level, the National EML Committee, they're very strict on looking at the evidence, because obviously we don't want to recommend something which has cost implications if there's no clear evidence. So it's not because of cost, it's because of, and the references are there. So that's my point about calcium.
no, Dr. Moran, let's not go out and the NOFSA, the international guidelines, ACOP, they've got committees that sit down and look at the evidence. If I'm looking for evidence that is against, I'll find it. If I'm looking for evidence that is pro, I'll find it. So, if there's American guidelines, there's COG, and everybody's singing one song, and there's another group that is singing another song, just like the days we denied HIV because it's AIDS. You've got to ask yourself, and I'm not saying on this one really I want to be pedantic. We cannot have international bodies with scientific bodies with evidence that is saying do this, and then we come and say calcium is of no effect.
Yeah, and I think what with before the registers, you've got government guidelines. And if you take America, for example, as what there's the task force, I forget the other letters for it, that make recommendations. There's an ACOP, and you'll often find the guidelines by the scientific grouping compared to, or by the grouping that represents specific, disciplines, might differ from the task force kind of thing. And that's what is happening here. With the national guideline, which is obviously a government driven kind of story, then we've got a body that only looks at that, and they are having different recommendations. So that's where the differences of any country will find those differences between what the national government says and what the bodies that are looking for a specific story will say. So I think we shouldn't leave here thinking that there's a problem. It happens anyway.
Yeah, so I'm not disagreeing with anything that's been said, but your talk didn't actually present the evidence from whatever studies for or against. So we're left with the situation that different bodies who are looking at the evidence are not necessarily agreeing. The other issue I wanted to bring up was the DEPO, which obviously is a big story for us because it's still the most commonly used contraception development. I think you mentioned APOC. Now that's an American organization. You said they're still promoting DEPO. But you said that in I think you were referring to 2014. More recently, there's been a lot of worry about medical.
Yeah.
You said that.
Yeah, ACOG.
But there are a lot of I think we're dishing it out. Do we need to relook at what we are telling patients when we dish it out? Because I don't think there's any discussion about whether it's bone or meningioma or anything like that. Do we just continue as we are, or should we be looking carefully at what everyone should be told before they start doing that?
So I think that's why I brought the slides in. Otherwise, I wouldn't have put it in. But I think that's important. I think we don't counsel these women. We just like, oh, contraception, yeah, okay, Depo or new estirate, you know. And I think that's something that we need to re-adjourn in terms of our younger patients, where we have alternate LARCs available. And we need to start counseling patients on the effect on bone, especially our young adolescents who are going to take it for long periods of time.
Yes, we hear about BMD, and obviously BMD will often there'll be some recovery that will happen.
Yes.
But until we are clear in our own minds, we can't go out there to communities and say things that we're not very clear about. I mean, when you talk about all these long reversible acting, whatever story, when it comes to progesterone, talk about amenorrhea or menstrual disturbance, talk about weight gain, talk about delaying, especially with technical. And those are the main what material information that makes the patient decide for or against. If you start adding another component that will confuse the patient, then it becomes difficult. So the issue is, have we seen in the framework increased fractures? And you mentioned 1 point something. I interpret that what is 1 point something the latest. In terms of this, you say out of 100 people, 1% would obviously. So that I think is still a bit of an area that we need to be a little bit cautious. And I think the Darian always made some pronouncement on this story or something like that. I remember when it was with HIV and whatever. I can't remember what you mentioned. But we just need to be a little bit cautious in terms of the story. As somebody mentioned, prevention of pregnancy is better than whatever the story is. So I think for that, what I would say, we need to be cautious. Let's mention material that will make the patient decide, not make the patient confused.
On that note, Dr. Maisa, we have navisterin. And for the longest of time, people understood, even the nurses who are in family planning, they know that you don't give Depo to a young girl.
Yeah.
So let's have that in mind. Postpartum, a young girl says, I want Jobo. Let's understand that Jobo is on history because they must still reach their peak bone mass, and that's where it matters. Because if we shortchange them that early, then we are really being harmed.
The challenge is availability.
Yeah, that's where now
that's where the challenge is. Even in the private pharmacy, you will often find into that. So that's where the challenge comes in. And to say what is worse between an unwanted pregnancy and this high polluted stories of women.
Maybe our procurement officer.
No, it's a company that provides whatever the is. It's not,
I don't know if you'd add on to that, Dr. Moran.
I just want to go back just to the statistics. This is one statistic you did present. This 1.17.
Yeah.
Was that percentage increase? That was the relative risk. So that basically means a 17% increase. So
it's a 17%.
On the confidence interval.
So you're talking about just the study of this?
That was just one study.
Yes, that is on their study. That's what we're studying.
Yes.
Yeah. So I mean, what's that? 300. This is what big. This is the one from
local.
Fine.
But not as you. should we like promote protein supplements and things? Because 1 gram per kilo of protein is like 70 to 80 grams, which is actually quite a bit to try and eat. Like 1 egg is 6 grams of protein. So if you're giving therefore, should we encourage protein? Because providing the protein intake is also really important for long term.
So how many eggs is that?
Yeah, how many eggs is that? I mean, like a dozen. I think in our counseling, it's important to promote dietary intake. No, but there's other sources of protein. Yeah, but there's other sources of protein. Mm.
Yeah,
Of eggs.
yeah, that's another thing. And allowing yourself to vent with the but yeah, thank you for that. And I think we're getting to the end of our year program. I'm still asking consultants to submit topics, and there is a year-end function in 2 weeks' time. Please respond. I was at the venue yesterday. It's awesome, right? Awesome. They had a children's party there. You don't want to miss, so we're gonna have a good time. Yeah, so please respond. The registrars have done a good job in preparation. The place is there, but it's awesome.
It is.
No, it's here in Glenwood. I couldn't believe that there's such a place in Glenwood. It's just down the road. Literally, yeah, beautiful. Yeah, safe parking.
Okay, thank you. Have a good weekend.